My name is Ken Nanny. I'm an attorney for Atrium Health. I have been working as an in-house hospital attorney for 30 years. The plan was a 3-year gig, but it's a pretty good place, I think, and I think it's a useful spot to put your time and energy and hopefully help some people. So today I'm going to chat with you a little bit about practice. We're going to talk about litigation. We're going to talk about medical harm. And if we have time, we're even going to do a little exercise, right? So, the data says that about 1 out of every 3 folks in this room will suffer a medical malpractice lawsuit sometime during your career. We have folks who plan to go into neurosurgery, OB, dental surgery. You guys are more at the top of the list. So I want to give you just a little background about kind of what this looks like and why we have this system, and maybe to think about how we can make it better. So let's talk about medical harm. We all know that when you're taking care of patients, there is no guarantee. In fact, statistically, most patients are going to receive some kind of harm or injury. A lot of data says that patients admitted to hospitals every year, about 100,000 of them die from infections, right? You have to think about, is that acceptable or not? There's a lot of debate in that space, but it's clear to say that medical harm, what we're talking about today, is really not the absence of any injury. There's an expected or anticipated amount of injury built into the system, right? Hopefully it's a little less today than it used to be. I was looking at some data just the other day about management of wartime injuries, comparing, the Civil War versus World War II versus World War I and what have you. And it's dramatic how about 42% of soldiers injured in battle during the Civil War died, a lot of them from infection or what have you. But whereas today, U.S. soldiers that are injured in battle and what have you, only about 10% of them die, even though the lethality of the weapons we use today is much more effective. The difference is the medical system is really better, right? But we know there's still going to be a certain number of folks that just aren't going to make it. So when we're talking about medical harm here, or harm caused by medicine, we have to realize not all injuries are preventable. Just raise your hand if you're perfect. Okay, all right, we got one over here, right? Neurosurgery? No, okay.
We're close.
All right.
Right.
Perfection is always the goal. It's never realistic, right? So, it's not just physicians. I don't know of any perfect human. I'm routinely reminded that humans are imperfect, including those in this room. And that's part of being a human, right? So we have a lot of systems, we have a lot of protocols, we have a lot of algorithms to help us kind of stay on track. One of my kids is a commercial flight student down in Florida at Emory-Riddle University, and they're big on checklists. They do checklists for everything. The reason they do checklists is because they say humans can't remember all the minutiae, all the detail to be really diligent and avoid error. They have to rely on these kinds of things routinely. And at least in the aviation industry, they've done a lot of good work in that space, but it is. So, talk a little bit more about error. How much error is okay? If, was there someone who's thinking about OBGYN over here, maybe? Yeah, tell me your name.
Sarah.
Sarah. Sarah, so how many babies do you think you might deliver during? Thousands. Let's say 5,000, okay? Busy career. So how many mistakes would be acceptable there? And I'm talking material mistakes where we have oxygen deprivation and long-term, functioning problems. Out of the 5,000, what's an acceptable error? Do what?
Hopefully 0.
0. Wait, is that realistic? So is it okay if we have 5 of those kids that have really bad outcomes, they can never walk the park like people in the street? How about one? Is one okay? It's challenging to think about how much error is acceptable. Yet, when you look at the resources that are put into programs, you look at the people, the staffing, the education, on some level, decisions are made to figure out how much error is acceptable, right? So I'm not encouraging error. I'm just saying you have to recognize it is part of the system. And what we talk about is how much error is okay. Now, if it's my kid, I'm always going to be upset about it, right? But if you step back and look at the statistics and the data, part of the way our system is set up is that there is a little bit of error. I'll tell you, my three kids were born here at CMC, and the last one was by C-section. Everything was great, but it was, I don't know, scheduled pretty early in the morning, 9:30 or so. And I remember I was in there, my wife's on the table, the doctor's cutting in and what have you. And I say, hey, how are you doing? Because he's looking kind of worn out. He says, this is the fourth today. And I was like, long night. He's like, yeah, I'm going to try to get some sleep later on. And everything worked well. But I was thinking, how much error is acceptable? Is it fair to push that doctor to that limit? Everything worked out really well. But, I think you have to think about what does the system look like. And I submit at some point, if you're in charge of the system or a little piece of the system, you've got to think about what's acceptable. Okay. So let's say that there is going to be error, and maybe there's error that's not just the acceptable part built into the system, but a little bit more extraordinary error, right? What's the right kind of punishment for the doctor, for the nurse, for the clinician, for the hospital administrator who developed that system to let it set up? If that family comes in and says to the court, look, my kid's never going to walk, my kid's never going to talk, this doctor is pushed beyond the normal limits, we have problems with the equipment, with machines, what have you, someone needs to pay. And recognize you can't really unring that bell when that kid has that serious neurological, right? If you go back and look at the Code of Hammurabi, this is the translation as best I understand it. If a physician make a large incision and kill the patients, or open a tumor with operating knife and cut out the eye, then the physician's hands shall be. And that's a little extreme. I kind of like mine. And my hunch is most people in here do as well. And I submit if we were to follow this model today, most people wouldn't be in this room. Well, you'd rather do something else than put yourself in that case, right? So we've determined that this kind of punishment, an eye for an eye, is not appropriate in the medical system, in part because we've run out of doctors pretty quick, right? So let's talk about the modern concept of the standard of care tied to tort law. Anybody familiar with torts? Right? For everyone else, it is not a French pastry, which tastes great, and I'd love to have one right now. But it's really the system that really deals with, we're talking about civil wrongs here, not criminal wrongs. Criminal wrongs can only be a crime against the government. So can I pick on you? Tell me your name. Ashley, if I were to come up and punch Ashley in the nose, right? Well, if she's trying to eat her breakfast here nicely. If she were to try to make a criminal complaint out, it's technically not up to her to make the decision. It's up to the district attorney to determine if there's a crime against the state here if I punch her in the nose, right? And so she might ask for it, but the district attorney and the law enforcement can evaluate the amount of evidence out there, decide to try to prosecute me or not. Now, let's say the government says, sorry, we don't have the resources, or we like him too much, or whatever. We're not going to file a criminal wrong or complaint against him. She could file a civil suit against me. She could hire her own attorneys. She could develop her own evidence. She'd get witness statements from everybody in here, and she would try to sue me for damages, right? Now, damages can only be financial, is what we're talking about here. On the criminal side, you could actually put me in jail, but only the government can really take away your liberty like that. See that distinction? So we're only talking about civil wrongs in this particular discussion this morning. So a tort is again from the Latin word tortus, which means twisted or wrongful conduct. And it's put in place as an opportunity for injured parties, whether a motor vehicle accident, malpractice case, or whatever, to seek a redress of grievances from those they think really harmed them. There's an old article that I used to discuss in this class, and it's from Italy from a number of years ago. And there was a young boy who had an appendectomy. He had the surgery, and he died post-surgery, right? And it turns out that about a week later, the surgeon who did the work had an unknown or unnamed black vehicle come along beside him while he was going along a cliff in Italy and run him off the road. It come out later that kid happened to be the son of a mob boss. There was never a clear link between the death of that surgeon and this particular bad outcome for this young child. But there was always suspicion that that was the way that those folks decided to make their complaint against the doctor, much like Hammurabi's code on some level. But the civil wrong system or the tort system allows for people to go through a process in front of a judge or a jury, seek financial damages, and hopefully that's a bit more civil than running people off the road. So that kind of thing might be the alternative. So let's talk about the elements of tort negligence: duty, breach, proximate cause, and damages. I will tell you that if you're in a car wreck or you have a medical malpractice case, you have to have all four elements of the tort in order to be successful in this country. A lot of people ask me, oh, you know what? I was nearly hit by that nut on the road this morning coming into the office. I can't believe I could have been killed. Can I sue him for that? No. Because you only have maybe three elements. You don't have the damages. You have to have actual injury. And it's got to be something that's measurable and material. In this situation, a common medical malpractice case might be, let's say that I go into the ER and say, look, doc, I've got this terrible chest pain. I've got a family history of cardiac events. It's in Chile. The doc looks at me and says, you know what? Just go on home, sleep it off. I'm not going to do the 15 lead EKG. I'm not going to run troponins on you, nothing like that. Just go on home and you know, call me tomorrow. And I go home and I pass. I would argue, look, that doctor probably had a duty to do a more thorough evaluation based on my presentation. They failed to do so. They breached their duty. I mean, if I can prove that my injuries, my death and, you know, loss of income and all that kind of stuff are approximate cause or the direct cause of the breach of duty, then I've got the elements of the tort, and I can go to court and I can try to ask for financial recovery from that doctor wherever I think made a mistake. Questions? Comments? Okay. Let's talk a little bit more about torts. You've got plaintiffs is that person who brings the lawsuit alleging that you were negligent. You have the defendant, who's also known as the tortfeasor. If someone comes up and calls you Mr. or Mrs. Tortfeasor, that is not a compliment. That means they believe you are someone who has committed a tort, which is, again, that twisted or wrongful conduct. So again, we talked about the standard care of the medical malpractice conduct, and that really helps establish what the duty is. So where do these duties come from? We utilize something what's called the same or similar communities test in North Carolina. So let me ask, I was looking at this map a little bit ago. Who's from the most rural community? Anybody? Anybody grow up in a really small town? Come on, somebody. Somebody came from somewhere other than, okay, tell me your name.
Latanya.
Latanya, where'd you grow up?
Small town in Jamaica.
In Jamaica, and how small? I mean, like a stoplight, two people, what?
No stoplights.
Okay.
We don't really have that.
Okay,
No.
okay, so pretty small. Was there a hospital in town? Okay. Was it a big hospital?
Yeah.
Okay. Did it have an MRI machine? I got you. So did it have neurosurgeons, you think? Probably not. Orthopedic surgeons? Pretty small place, huh? Probably beautiful area to grow up. Okay. Who grew up in a really big town? Anybody? Yep, over here, yeah. Yeah, where'd you grow up?
Baltimore.
Baltimore? Okay. I mean, you got John Hopkins right there.
Baltimore.
There's a number of big hospitals there in Baltimore. You have access to a lot of pretty high tech goods and services. There's some challenges in Baltimore, but you probably do have access to a greater access of diagnostic and therapeutic capabilities. Right? I love Jamaica, but the standard of care in the small community you're talking about ought to be seen as different, in that it would be unfair to hold the physicians in that small community. What's the name of the community again?
It's called Lucy.
Lucy. It would be unfair to hold the physicians in Lucy to the same standard of care as you might hold those doctors practicing in the largest hospital in the world, because they don't have the resources. They don't have, the expert right down the hall they can go chat with, what have you. And consequently, in North Carolina, the standard of care fluctuates. It changes geographically based on where you happen to be and where you happen to get that level of care. So where do you think is the highest level of medical care in this state? Any idea? Charlotte?
I said the triad.
Oh, the triad?
Charlotte would be my second.
Yeah, I think I'm there with you, actually. I think the triad, probably Duke has a lot of specialties. They've got a closed medical staff. They got a lot of stuff going on up there. I know a couple of the in-house attorneys at Duke, but they always say, no, we're not at the top. And so I think if you're treating a patient in that environment versus, I'll pick on Lucy again, or a really small community in North Carolina, you're consequently going to have different expectations. And so I just want to make it clear, in this state, there is not a uniform standard of care. It's going to vary based on where you are and what you have access to. And I submit it might even vary a little bit based on the time of day, the day of the week. If it's 4th of July, it's going to be different than maybe today, right? And so it is going to be a little bit flexible. And so consequently, when you're trying to establish what that duty is, it's going to vary just a little bit. You guys really see the laser? I really can't. Anyway, it's going to vary a little bit. And so consequently, figuring out what the breach is going to be a little bit flexible. Yes.
Is that standard about location, or like what if in this city, like there's a hospital that has more funding than another one, like a mile away?
There you go. It's going to be based on the particular square footage where the patient is standing. So to your point, it might vary within a city a little bit, right? So if you're over here in the trauma center, just across the street, it's going to be different than if you're in a doctor's office, 10 miles away, right? They both might be in the city of Charlotte, but the access to the resources the clinicians have, that's the key component, right? Does that answer your question?
What defines that access though? Is it like money or?
Money is part of it, but it's more than money, right? Maybe it depends on if the patient comes in and they have particular signs and symptoms. Do you need a specialist? Do you need an MRI machine? Do you need certain kind of high-tech lab evaluations, that kind of stuff? It's flexible based on whatever the needs of the patient happen to be. And so consequently, it is a little bit split. So who do you think helps establish what the duty is, recognizing it could change a little bit? Other doctors, right? That's going to be the key. So it's going to be those people, maybe even people in this room who are running into you in 4, 10, or 15, or 20 years later, talking about, wait a minute, I know that place. I know what resources you have available to you. I know what you could have done or what you should have done. It's insiders who have good knowledge to understand what the real standard of care is. And they're frequently debated. Okay. So, again, there's no uniform standard here in the state of North Carolina. It's going to vary. It's established by expert testimony. In this state, that's got to be a practicing physician with the same kind of specialty and expertise and training as the person who is the alleged tortfeasor. So it's really a peer who's going to evaluate and opine either in your favor or against you. So I encourage you, when you're in the midst of a really difficult situation and you're thinking this could be one of those bad situations, what would the other people in this room think about your actions and behavior if they were looking over your shoulder at that exact incident? Well, that's the kind of test that's being used out there in our civil justice system. If they would say, look, they did everything reasonably they could, then you're going to be okay on in this space. If they say, look, they really could have done more, and I know it and they know it, that's when I think you need to think twice. Yes.
If it's a peer doing the analysis, doesn't that kind of make them the judge if it's only one person versus being a jury?
Oh, great question. A little bit, but the thing is, and we're going to talk about Rule 9J of the North Carolina Rules of Civil Procedure in just a moment. You have to have that expert who's going to opine against you that says the tort's been committed because they've evaluated the facts and circumstances in the record in order to even get to court. So they're a gatekeeper. Now, if you get to court, you still might be able to defeat them because you might have a good expert on your own that says, wait a minute, my experts are better than yours. And I'm going to convince the jury that I did the best I could. But it's a gatekeeping system in order to even get into court in this state. In a lot of states, you've got to have that expert. And the reason they put that in place was so that it was a way to avoid frivolous lawsuits where a patient would say, look, I'm injured and I want some compensation and I'm going to take you to court. And the doctor, the hospital girl's got to spend a lot of time and energy just fooling with that even before you get to it. Yeah. I will say it's the same or similar communities test. It doesn't have to be somebody from the triad who testifies against the doctor from the triad. It could be someone who's from a similar community, even outside of the state, if they are familiar with the kinds of resources that are typically available in that particular kind of situation, right? So, for example, whenever I'm looking at medical malpractice cases at CMC, I always try to find a doctor who works at another level one trauma center, right? It's not an exact match, but it's pretty close. I don't want a doctor who works at a community hospital to be my expert close. They just aren't going to be able to truly opine in the standard of care. So, all right. Statute of limitations in North Carolina says, I clicked one too much. Healthcare. Hopefully that's not important. You can't take forever to sue people. Memories fade, evidence gets cold, standards of care change, and people have a hard time remembering what was normal or what was the standard of care 10, 15, 20 years ago, what have you. And so we do have certain limitations on how long an injured party has to bring their claim to the court and file it. You got to solve the first one. So in North Carolina, for regular medical malpractice, it's a 3-year statute of limitations. So you need to worry about stuff for about 3 years, unless we're in some other particular categories. Any idea how long people think it is if you die? If the patient dies? It's 3 years for regular. It's 2 years for death. And the theory is that is such a clear and acknowledged injury that people ought not to rest on their laurels. Sometimes people actually are injured by medical malpractice, but they don't appreciate it or recognize it. They just think it's a normal kind of pain after the surgery or what have you. I had a case a few years back where we had a patient who was retained from our buddy case. I think that's probably not anyway. This particular patient, they got opened up and they'd had a number of surgeries before, and they found a piece of plastic like you would find like shrink wrap on top of a little plastic vial or what have you. The challenge is this patient had a lot of serious complications and had 4 surgeries in 2 years by 4 different doctors. No one could ever figure out where that piece of plastic came from. Right? Tough case. The other doctors were back. But a retained from a money case, like a sponge or a clamp or a piece of plastic, parties have up to 10 years to go ahead and file that case. And the theory is that that's likely not going to happen absent medical malpractice, and people get a little extra time. And routinely, you don't always recognize that there is malpractice. Talk about kids. Pediatricians in here? Yep. Got a couple of folks in the UN as well. So the rule in North Carolina is, used to be different, but they changed this a couple years back. A minor child has, before they reach the age of 10, to file a medical malpractice suit against the doctor they allege injured them, or a longer period, whichever one is greater. So if you have a 9-year-old and they didn't die, they don't have retained foreign body, they have up until their age of 12. But if they're an infant, they have up until the age of 10. Everybody with me on that? So of course, a 10-year-old is not going to walk into court themselves, but it's their parents or guardians who might actually file that case. All right. You guys think this is fair? This time limit's okay? Should be longer. It used to be in North Carolina for minors, they had up until the age of 19. So it was until they hit the age of majority at 18, then plus 1 extra year to file the suit. I remember a case we had some years ago, and they filed suit based on a birth injury, and the kid was in high school. And it was really tough because the doctor had retired, some of the nurses had passed away, and the records were really old with jargon people don't use today. It was a tough case. We ended up settling that case. The kid had a lot of problems. I don't really know whether it came from a birth injury or not. But yeah, we only have a teacher. In addition to the statute of limitations, you have an extra 120 days to secure that North Carolina Rules of Civil Procedure Rule 9J expert that we talked about, that experienced peer to get their expert. And the theory is, without that, you can't even get into court. In fact, if someone actually files a medical malpractice suit against you without that expert opinion, all we have to do is file a simple motion and the court will toss it out. And if people miss their statute of limitations, they're just out of luck. The theory is that the court uses is don't rest on your laurels. It's a question.
Who's paying these like expert opinions, and like what is their motivation or lack thereof to like push it through to a trial as an expert?
So some experts feel that they are engaging in what I call justice. They see failings in the system. They might see failings in a particular doctor or colleague, and they feel like it's the right thing to send a message about what behavior is unacceptable. I will say there are other experts that I'm going to call hired guns. They get paid substantially. An expert can't get paid for what they say. They can get paid for time. And many of them will make pretty good money doing this. And they will ride the circuit and they'll go out there. I mean, it's not just doctors, it's nurses and what have you. And there's a number that we're well aware of. But I will say, I've also encountered situations where there is a really bad outcome, and the physician who has to clean up the mess is where the plaintiff's attorney will go and say, look, this is a terrible situation. This family didn't plan for this. They don't have the resources. Someone needs to come up with at least the money to take care of this terrible situation. Who's going to do it and what's going to happen? And some of the more successful cases are where that doctor who's doing their best to rehab the patient, take care of the problem, says, look, I know somebody. Why don't you talk to them? And so maybe that's part of the civil justice system. But it's a good question. What is the motivation? I think it varies. I want to talk about other potential bars to be aware of. Contributory negligence. Is that a question? No, you're just ready. Okay. So, North Carolina is one of, I think, only 3 states in the whole country that still has this old English common law concept of contributory negligence. And it says, don't come to the court with unclean hands seeking justice. So if the injured party is at least 1% or more responsible for their own injury, they can recover nothing in damages from anybody else. So when you're giving those instructions to that patient about, I want you to call me if after that you bump on the head, you start, feeling nauseous or vomiting or passing out or dizzy or what have you, and they don't, and they do have that bad subdural bleed. Maybe you can say, look, I had clear instructions that responsible patient had an obligation to help take care of themselves, to follow my instructions. If they failed to do so, at least 1% of the fault is on them, and I shouldn't have to pay out any. Now, I'll tell you that's an older model. It was developed hundreds of years ago in England. It is comparative negligence is the more modern concept. Now, I'll tell you a thing about contributory negligence in the context of the same argument. Let's say you're in a bad car wreck, you get injured. And has anyone ever driven a car while you're not wearing a seatbelt? Yeah. So what's the purpose of the seatbelt?
Same.
It's to reduce injuries, right? So let's say you have a serious injury, and the other party was speeding, or they ran through the stop sign, and they say, "Look, wait a minute, you should have been wearing the seatbelt. Gosh, you're a physician, for God's sake. You know this. I don't care how busy you are. You're injured because you hit your head because you weren't wearing the seatbelt. Don't blame me. You're at least 1% responsible for your very own injury. I don't care how fast I was going." In North Carolina, they're going to use that contributory negligence bar and try to duck any responsibility. I will tell you, this is a very pro-business and pro-medical standard. It attracts more physicians to the state. It probably attracts more businesses to the state because it allows them to point out even a small amount of fault on the other side and pay out that. Comparative negligence, more modern standard, it really apportions the degree of fault. So let's say if the damages are $100,000 from that car wreck, and the tortfeasor is 70% responsible, and the injured party is 30% responsible, the court will just make the tortfeasor pay $70,000, right? So they're still going to pay something, just not as much. It's not a complete bar like you would have in. Yes.
When you say pay and the settlements and all of that, is it out of the physician's pocketbook? Is it, for instance, Atrium's pocketbook? Who's paying?
Who's paying? Great question. Who's paying? Well, the issue is,
Okay.
I heard Adrian in the restaurant. The question is, who's the defendant? Who gets sued? So, these days, more than 50% of physicians in this country are employed by healthcare systems. And in that situation, who wants to be employed by a hospital or health system? Anybody? Who wants to be an individual? Which is fine. I don't really care. And there's a concept called respondeat superior. It's a very old English common law concept, and it means literally, let the master answer for the acts of the servant. Let the master answer for the acts of the servant. You think about it, very old England, hundreds of years ago, you might have had a cobbler who might have a young apprentice who would help them cook the leather, whatever they were going to do to make shoes and that kind of thing. And if that apprentice in the course of their work made a mistake, committed a tort, injured somebody, that master, that cobbler, would be responsible for their actions and responsible for paying any damages for any tort committed by that person in the course and scope of the work they do. And that concept is translated today. So your employer, if you work for a hospital or healthcare system, is legally responsible for the damages you have to incur while you're working on behalf of that employer. But let's say if you're moonlighting for somebody else completely different, and maybe you happen to be employed by Atrium, but you're moonlighting for, Dr. Smith on the side, Atrium Health is going to say, wait a minute, if you were not in the course and scope of what you're doing for us, we have no responsibility, right? So what most people do is most people, raise your hand if you're inherently very well. If you're inherently very wealthy, please raise your hand. Yeah, I don't raise my hand either. Most people use insurance to pay off those damages, right? And I will tell you, Atrium has a lot of insurance because we have a lot of risk. We do a pretty robust a program to evaluate that kind of risk. And I will tell you that we have a lot of money. So if you work for us, if it's in the course and scope of what you're doing for us, and God forbid there is a tort, you'll be covered financially. Yeah.
Yeah, at least for like the VA physicians there, if you try and sue them, you'll be suing the federal government.
Yeah, that's claim that. Yeah, they kind of go out of routine civil cases anyway. And they do put a limitation on it. A lot of plaintiffs don't like that because they say they don't get paid the full measure of their damages because the federal government doesn't want to be as responsible.
How do you decide based on like their injuries, how much money they get?
Oh, gosh.
Like, it seems like it's very kind of,
Subjective?
yeah.
All right, let me do, we have just a couple of questions. Let's say we have a terrible tort where, somebody is driving really fast and trying to get to the fourth floor of the medical education building. And they don't want to miss this great lecture and they're going too quick and they kind of go through the stop sign and they hit somebody and they break their right arm, their dominant arm. It is a bad fracture. It's complex. And down in the wrist, there's a lot of little cracks too, right? How much would someone have to pay you? What would it be worth to let you be that injured party? Let me pick on you. To have a complex fracture in your dominant arm, $100,000. Is that fair?
You're gonna be a urologist.
I was gonna say less.
Okay, all right, okay, I love this guy. 25,000, yeah, 25,000.
Can't do surgery and have forever.
Wait, you're out of work. Wait, how long are you out of work?
At least a couple weeks.
At least a couple weeks.
Wait,
Wait, okay. Let me go back to the work thing. What if it's a complex fracture that doesn't heal right? Could that happen? Yeah. So who's the neurosurgeon?
He's gonna be a urologist.
Okay, that's still pretty important, right? Now, you know, it's good to be able to use your hands. If you have permanent loss of appropriate sensation in your dominant hand for the rest of your life, how much will that impact your earning potential? If you have to disclose that with every medical staff application, oh, my right hand doesn't work quite right. Pain and suffering.
Correct.
10 million, okay? So
Then Atrium will settle.
taking myself for fun.
Because he probably makes more than 5 million in his life.
Does it change if it's like, okay, I'm gonna pay everything now, or do we say you owe me this much for like? and
Sometimes we'll do a
somebody-
structured tenure settlement, you know,
Yeah.
every year. It's extraordinarily subjective as to how much pain and suffering is out there. You can establish through expert testimony, economic experts and what have you, how much money you're likely to lose. And I will say, it's much better to not hit the neurosurgeon in their dominant hand, because they're gonna have a higher earning potential, right? Pain and suffering is capped in this state. Yes.
So in this scenario, it's like, say it's me, a medical student,
Yeah.
or like, not another physician, not someone who comes from money who does this, and you hit a neurosurgeon
Yeah.
and they ask me for $20 million. Okay, sure, but I don't have $20 million.
Okay, great question. You have $20 million. Maybe you've got some insurance.
Not $20 million worth.
The insurance has two duties. One, to defend you, to hire attorneys to defend you in court, and two, to pay, to settle and try to limit the damages directly against you if at all possible. And once they exhaust the amount of money they have laid out for you, they're done. They step back and it's on you. And I'll tell you, in North Carolina, you can get a judgment against you, which is good for 10 years. Then you can renew it once. So it's really a 20-year judgment if you're clever. So they would have the right to come after any material assets you might acquire in the next 20 years. So it's good to have insurance. I'll tell you, there's a cap again on pain and suffering in the state of North Carolina. It's capped at $500,000 unless you lose the limb or you die from it. Plus, there's a little interest inflator on it, and they do that because they say people would have some pain and suffering, but some people would fake, right? And so there's a little bit of cap in there. Was there another question? Yeah.
You were talking about like the witnesses to testify. What
Yes.
do you guys look for in a witness? Is it
a physician that's been practicing for a while? I know you touched upon like whether they work in a community or, like an academic center, but
Yeah, yeah. How do you find a good expert witness?
yeah.
You do a lot of interviewing with them, and I'll bet there's people in this room that you think might be a good expert witness and people that would not. People that are believable, people that seem authentic, people that maybe are not perfect, people that recognize errors do happen, right? People that other folks trust. It is a slippery concept. But yeah, it's hard to find the right expert, especially in those specialties. Yeah. Yeah.
So how do the boards apply that concept, when the defendant one of several?
Oh, but there's a lot of different factors, right? When 5 people come together at a stop sign and they all wreck, right? Or there's multiple doctors involved there. If I'm the injured party, I'm gonna sue everybody and let the tortfeasors fight it out amongst themselves. So they start pointing fingers at each other. No, you're more at fault. No, you're more at fault. And you'll hire your own experts to do the work. That's what I'm doing.
Out like the relationship between physicians and other like clinical persons.
APPs, folks might think
Yeah,
about it, that kind of thing.
the Supreme Court like rule about the nurse anesthetist being just as or more responsible than anesthesiologists now.
There's a modern trend to say that CRNAs and APPs and maybe RN, maybe respiratory therapists, I'm not sure where it's going to end, are independent and don't have to necessarily be supervised by a physician. But there's tons of situations where the doctor says, respiratory therapist, I want you to go run these blood gases right now, and I want you to tell me if they're, outside of this particular range. And so part of the issue is trying to establish who's at fault in these cases. The particular case I think you're talking about is a real tragic case where there's a young girl who was having a cardiac procedure, and the anesthesiologist developed the anesthesia plan. And this kid, she had a lot of serious comorbidities. And the allegation is that the CRNA turned up the gas volume too quick. The CRNA was very experienced, and so was the pediatric anesthesiologist. And the pediatric anesthesiologist said, I didn't tell him to do it that quick. And the CRNA said, I only did what the doctor told me. And the plaintiff's attorneys loved it because they got the defendants fighting amongst themselves, right? So there is a modern trend to allow CRNAs and others to be independently responsible, independent from physician by supervision. That's still a fuzzy kind of gray area based on facts and circumstances. I just need to move on in the interest of time. About a couple of minutes. We talked about Rule 9J. There's an exception for residency cases, and that is where the penalty. So I think those are the clean part of my say there should be a clamp left in your belly. Sure, yeah.
What would you say was a fair amount to Jack's broken arm?
It's ultimately up to the jury to figure out how much your injury is worth. You would bring in experts to testify on your behalf. The other side would say, oh, he's really not that bad off. He's a baker, whatever. And so there are caps on pain and suffering, but it comes down to an argument in front of the court to try to establish what it is. It could be a lot, especially if he's got substantial earning potential.
But it can't go over 500,000.
Not for pain and suffering, but your loss of income, sure, or your medical bills, or loss of consortium. Maybe people in your house rely on you for all sorts of things. Maybe you can't change your baby's diaper anymore. What is that? Right? Let's talk about apologies here. Joint Commission has a standard they came out with a few years ago, and they said if there's material injury to a patient, unexpected patient death, or serious injury or the risk thereof, I never know what the risk thereof is. The expectation as the relevant healthcare provider inform the patient and explain what happened. So in North Carolina, there happens to be a Rule 11. The Rule 11 says an apology by a medical provider cannot be used in court to prove that they were negligent. Why do you think they have that rule?
Does everybody sue?
Because everybody would sue. It's also to encourage healthcare providers to be more candid with patients and to have that kind of discussion. Raise your hand if you've ever been a patient in a hospital. I had some unexpected kidney surgery, about a year ago, actually two of them within 2 weeks. Worked out really well, but you know, I was on the other side and the CRNA is poking around my mouth, making sure I don't have any loose teeth. And I was thinking, wait a minute, what's going on? I'm on the wrong side of the bar here. It all worked out. Great healthcare provider. But I submit everybody in this room at some point will be the patient or you will have a loved one who is the patient. And you're hoping the amount of acceptable medical error is not going to come. I want to take just a moment and do a little exercise about colleagues. And I will tell you, here, I'll jump to this last slide. The VA did an experiment in apologies a number of years ago. The Veterans Administration purposely made a point to go and identify every material or even significant error for a patient and promptly disclose it to the patient. They thought it was based on not just legal, but ethical and moral principles. The number of claims increased, whether it's malpractice claims or people saying, look, I haven't filed the lawsuit yet, but I'm about to. Let's go ahead and settle. But the average cost per claim actually decreased. There's a net savings to the Veterans Administration, and patients seem to say they had a better experience. They appreciated clinicians recognizing when real error takes place and letting the patient know. Now, I'm sure there would have been some cases where medical error took place and the patient would have no clue, no idea, because they didn't have the knowledge or understanding to figure out what was really going on. But at least in the VA experiment, they thought overall it was a net gain, not just on the financial side, but maybe on the ethical side. So I want you to ask yourself, if you're a family member or ever harmed, the chances are what happened to somebody more than one time. Do you really want that healthcare provider to be straight with you and talk about what happened? Or do you expect them to use fancy words and dodge the question? And maybe it's not you, maybe it's a close family member who doesn't have your medical knowledge. So I'm going to pass out this little case study. I'd like folks to take a few moments to read it. So I'm just going to start passing these out. I'm not certain we have enough for everybody, so some people might have to share. And so I'm going to ask people to pair up with one other person. We're going to.
So I have a quick question.
Yes.
If you have consented a patient to the risk of the surgery and like you nick a valve, but you repair it and like they have no no valve.
Damages?
Yeah, no damages. Can they sue you for that? Like if you just look, I mean, obviously you're gonna disclose that to them, like, oh, we had the valve, but we repaired it. You know, had the general surgeon come in and look at it, everything was good.
Most plaintiffs' attorneys won't take that case.
Okay.
Because either the damages are zero or they're so close to zero that it's not worth it.
Okay.
Yeah, good question.
But what if it is damaged and if they do have like,
Serious injury.
they have like side effects, but they were consented, like she said. They knew that was a risk.
So maybe they appreciate that there is some risk associated. Maybe it's a high-risk procedure or high-risk patient, right? Then you would go back and have your experts say, part of the duty or the obligation is to disclose the risk and let the patient make a decision. And the doctor went forward with that. So good question. So that's a substantial offense. It really is. So let's take just a few moments. Take a look at this scenario, if you would. Please read through it. And I ask you to buddy up with a partner. And we're going to do a little quick apology experiment. So we got two folks. Somebody can be Dr. Smith. And somebody can be Isabella. Now, if you look at the facts of this particular case, pretty clear. If it wasn't. This patient should have been put on blood thinners, and the Dr. Smith, just missed it. They were busy. They had a lot of patients with similar problems, whatever. There's reasons for the mistake. This patient had a stroke. They have substantial debility. They're never gonna be like they were before. You go in, somebody chooses who's gonna be Isabella. When you go in, buddy up with three people. Someone's gonna be Isabella and somebody's gonna be Dr. Smith. And Isabella, I'd like you to go in with the knowledge that you have, not only from today's discussion, but also all your medical knowledge and history, and what have you. And go in and have that discussion and ask Dr. Smith why this happened. And Dr. Smith, I'd like you to try to explain it and consider what you might do in such a situation when you're talking to a skilled person who knows as much as you do about what's appropriate medicine in this case. So I'm going to give you guys a couple minutes, buddy up, and go ahead and start, and I'll come around and start chatting with people. Everybody with me? Okay. So first off, someone choose who's going to be Dr. Smith and who's going to be Isabella.
Sorry.
I guess I just didn't.
All right, ask me your question. My favorite pizza.
So like, we're saying, you know, might not get it, and you never get no way.
Like, what if it's like males and yeah. Have like horrible spots on my tongue. I don't know. I guess that's
Maybe that's enough. Are you
Yeah, but I had one of the easy and like he has I
feel like I'm trying to do some nice songs to get there could have been a fine scenario. So like, oh, maybe like I didn't play the ring, but maybe I didn't document well. And I hear like absolutely not working. It would have been like, oh, well, we were working in Butler and the island. So I couldn't do blood thinners. Maybe we were trying to figure that out. And maybe the records didn't get pushed through into the
I mean,
My ex, my stuff, I feel like saying. Like if I feel like you know.
Example for you, maybe from that experience. That make it all far when you do this, like, how long
It's like, yeah.
and then it's like,
And then like. It's- You know what I mean?
No,
They're like, no, it's Easter bug. Yeah. I saw. It's like Pennsylvania. Yeah.
and when they come in, I kind of like, stop.
Modern and too much.
You got it already.
Yeah, like.
Yeah, I stick around and distract you. Like you can like the IBC.
Actually, back to me, but it's really
Yeah, like I'm like the IBC have next week here. Yeah, you know that they're just like dissecting.
You like this place?
Yeah, it's really good. Like, just dissecting leg, I guess the is pretty. Yeah, yeah. It's like help them Boston, yeah. Where's both? Which is like pretty safe. I'm kind of like.
I like what they carry, you know, like.
Is why they have. My name and then I'm like.
okay, let me ask folks, if you were Isabella, please raise your hand. Isabella?
Just a five, so.
So you were talking with the doctor who allegedly put your dad in a nursing home. Are you okay with the doctor's explanation? Especially when you go to discuss it with your dad. If he trusts you, you're the doctor in the family.
Little unsettling.
You're okay, well. Good, cause I mean, it's a tough situation, right? Excuse me. Are you okay with Dr. Smith's explanation?
I think I understand their explanation, but I don't like their explanation
Okay, why not?
because it doesn't undo the damage that's already been done.
That bill can't really be upheld. So if your dad needs rehab for, I don't know, 6 months, are you gonna pay for that? Why not? He's your dad.
Responsibility.
Whose responsibility is it?
My personal opinion, it would fall to the cause. Who's responsible